First of all, welcome. I know schedules are really busy right now. Journal clubs are always my favorite sessions on the books here at Dime. We bring a smaller and really engaged group together. We look at a recently published sort of piece of work that we believe is really important to the field. We are delighted to welcome the authors of that work to take us behind the scenes a little bit, share a little bit of how this came together, the impetus for the work, and also from the author's perspective, why this is so important and the call to action. And then we throw it open to a good discussion. So let's do some housekeeping really quickly. First of all, just to fully disclose, we are recording today's session, so keep that in mind during Q&A. We also really do encourage engagement here. We do keep these groups smaller. It's a meeting format, not a webinar. So, when it does come to Q&A, when Cindy finishes her presentation, I'll invite all of you to turn on your cameras if you're somewhere where you're able, and you can ask questions in a few ways. You can drop them in the chat or the Q&A while Cindy's speaking, or you can raise your hand, not like this, but using the participant menu in the Zoom. And with that, this is such an important topic and something we've been thinking about so much at Dime. Delighted to welcome Cynthia Sieck to come. And actually, Cindy, I didn't even ask you about pronouncing your last name, so please correct me if I've got that wrong. I want to make sure I get it right.
You did.
Fantastic. That was lucky. Definitely more by luck than good judgment. Thank you for being with us today. I loved the paper. And if you wouldn't mind getting us started by introducing yourself to everyone on the line, and then you just guide me through the couple of slides you've got to present, and then we'll start our conversation.
Sure. And I should tell you that the slides have animation on them. I don't know if that's going to be annoying or not, but we'll figure it out.
We'll figure it out.
Yep. So thank you for that introduction. I'm Cynthia Sieck, and I am a health services researcher and associate professor in the Department of Family and Community Medicine, and in a center called Catalyst, which is the Center for Advancement of Team Science, Analytics, and Systems Thinking at Ohio State University. My background is in health behavior and health education, and a lot of the work that I do is in patient engagement and health information technology. And so when you think about how those two things fit together, the idea of addressing digital inclusion and making sure that everybody can make use of the wonderful digital tools that we have available that are growing all the time, that's kind of where those two parts intersect. And I'm really excited to talk with you all today. It looks like, there's a lot of different perspectives in this group. And so I'm really looking forward to a lively and engaging discussion. So if you want to go to the next slide, that's where the animation comes in. I just want to acknowledge my collaborators on the article we're discussing today, Amy Schoen, Jill Kastick, Bill Callahan, and Angela Saphir. And I want to particularly note the National Digital Inclusion Alliance, which is a fantastic digital inclusion advocacy organization. And they focus on digital inclusion broadly, so beyond the healthcare realm that we'll be talking about today. And they have a lot of really wonderful resources related to policy and research and tools that promote digital inclusion. So I would encourage you to check them out if you haven't already. So on the next slide, I just want to start with a few definitions so we're all on the same page. First, social determinants of health. Those are conditions outside of the person that are based in the places that we live, learn, work, and play that have an impact on our health outcomes or our quality of life. Digital literacy. This is the ability to use information and communication technologies and addresses both the cognitive and technical skills required to do that. And then finally, digital access. And this relates to a person's ability to participate fully in a digital society. So having all of the tools and the technology that allow that participation to happen. And this is where it's really important to consider how individuals access digital tools. Because a lot of times we think that everyone has the internet in their home, or they have a smartphone, or they can use public Wi-Fi spots, but those options are not all equal. Smartphones that rely on data plans have data limits to them. Families may share one device among a whole family, and so they may have concerns about privacy as well as limitations on data. And public Wi-Fi requires getting to a spot where that's available. Jennifer and I were just talking when we came on about, the organizations that would, like job and family service organizations that extended their Wi-Fi to parking lots so that during COVID, people could come and apply for jobs or apply for assistance, in the parking lot in a safe manner. That's a really different way of accessing the internet. And public Wi-Fi has privacy concerns too. So that's something to keep in mind as we talk about digital inclusion and what that means. So if you can go to the next slide. We suggest in our article that we need to view digital inclusion as a social determinant of health. And digital inclusion here means digital literacy and access. And in today's world, digital inclusion and digital access can impact all of these other social determinants of health. And that's not a new idea, but it's really, we've seen the impact of that a whole lot, especially with restrictions due to COVID. So, for example, related to access to food, the ability to readily and reliably use the internet and online resources helps you to find food banks in your area or places that would deliver groceries or fresh food. And it also helps you connect with safety net programs like SNAP. Or in the area of economic stability, employment applications these days are often online or accessed through a QR code with your smartphone, and you need skills and tools to be able to utilize that. Now, if you can click the next thing. For healthcare in particular, we've seen an increased reliance on the internet. And that makes a lot of sense because it offers significant conveniences over things like waiting on the phone or coming into a clinic for something that could be handled by a telehealth. So we see this in access to care, so scheduling an appointment or using telehealth. Right now in particular, we see this for vaccine and testing for COVID. And I mean, that's really helpful right now to get, a lot of information to a lot of people very quickly, but only if you have the skills and the resources to utilize it. So I don't know how people have done with scheduling their COVID vaccines, but I know, when I scheduled my appointment for my elderly mom, that required going to our state's website, checking that, and then checking the vaccine location website, then registering her, then confirming registration in her email, and then I could finally schedule an appointment. And then when I got to the appointment, there's a QR code that I had to show them. So that's a lot of steps for something that's very important. And those steps certainly made it easy. It took me about 10 minutes, but she wouldn't have been able to do it. So taking advantage of these technologies in a way that doesn't leave people behind is really where we need our focus to be. So you can go to the next slide. In this article, our team makes 3 main recommendations. We'll let the animation catch up. So the first is for organizations to take a population level approach and implement a digital inclusion informed approach to understanding the population that you're caring for. If you want to just click through all of the animation on this slide, that's probably going to be better. So what this means is knowing what the needs of your community are. So you can look at resources like the American Community Survey or a really helpful website called Internet is Infrastructure, which can provide you with information like internet subscription rates and device ownership at the census tract level. So what you see in that little map there is this detail for Columbus, Ohio, which is where I'm based. It's the capital of Ohio, and we have a population of over 1.6 million people. So you would assume, it would be easy to assume that most people would have, accessible and reliable internet. But if you take a closer look at this map, what you see is the blue is where people have good internet access, and the orange and red spots are where people have less access. So you'll see these swaths of blue where these people are set, they've got good access. But you see these pockets of red and orange where it's more of a challenge. And for healthcare organizations to know where those are helps them to better direct their resources and know what their population needs are. The second part of this population level part is knowing where you can send people for support. So knowing what types of support in terms of digital skills training or access to low-cost devices are available to patients in your area. Often you'll find these things in local libraries or community organizations, or the United Way's 211 website also can be a source of finding that information. So then on the next slide, the next recommendation is at the patient level. And this suggests that we need to systematically assess an individual patient's access. And that means access in terms of their access to devices, their access to the internet, their digital skills, support they have available. So asking, do you have someone at home who can help you? And their willingness to use the internet. A lot of times people may have these skills, but they may be not unwilling to use them in a healthcare context. So understanding all of that can help us know what each person's needs are. And this kind of assessment is not common, although it may be happening more because we've really learned how important this is with COVID. But if you combine this kind of assessment with the recommendation before it about knowing what services are available in your area, then a healthcare system is in a much better position to help connect patients with the tools and the skills that they need. So then our last big recommendation on the next slide is to partner with community organizations to address digital inclusion. Organizations like area associations on aging, libraries, local community centers, a lot of them are already offering training and digital skill development programs, particularly libraries. So healthcare systems need to be aware of where those resources are, because again, that lets them direct patients where they need to go, and then expands the capacity to get people up and ready to use the internet. So the last thing I want to talk about is just one example of a community partnership here in Ohio that does a lot of great work partnering with multiple organizations to address the digital divide. And this is called the Pact Organization. Pact stands for Partners Achieving Community Transformation. And it serves the Near East Side neighborhood just outside of Columbus. And it's been around for about 10 years. They do a lot of work to address economic, education, and health needs of this community. So when schools and organizations went virtual because of COVID, they had to adapt to address the digital divide in this community. And if you can go on to the next slide, you'll see that they received 2 major grants to help them do this work. And then the next slide shows you where they focused their efforts. They focused on getting reliable in-home broadband to folks, getting them devices if they didn't already have them, and then implementing a digital literacy training strategy. And if you go to the next slide, they also did a comprehensive in-person survey of the neighborhood. Even during COVID, people went out with masks on, and they did this because they knew that this was an issue and people aren't going to complete the survey online. So they had an incredible response rate. I think it was like 90% response rate, which is quite impressive. Yeah. And they found that 40% of their residents did not have reliable internet. 11 didn't have internet at all, and 19 relied on cell phone data. And if you think about, relying on cell phone data for your internet access during COVID, if you have kids at home, if you have parents who are able to work from home or are applying for, jobs and whatnot online, that's going to eat up your data in a heartbeat. And so, they recognized that this need was there. They also recognized that cost was the biggest reason that people did not have reliable internet. And while there are programs available to provide discounts and subsidies for devices and for the internet, most people were not aware of them. And so I think that is there one more slide? Nope, no more slides. But the last part of this that I want to say is that as part of their digital inclusion or digital literacy training, the last step in there, they partnered with Ohio State University to provide technical support to people in setting up and using devices. And then they also partnered with my department, Family and Community Medicine, to provide training specific to using telehealth, patient portals, other online tools to address their health. And so we just got this really underway in February. So I don't have really any data to tell you about yet, but it's what I hear from the community members is that it's super helpful to have both those levels, people helping you learn how to use a device and how to access the internet, as well as then taking that next step and focusing that education on a specific type of application. So before you all ask me anything, just to kind of sum up, the point of this is that we need to think about all of the components that are involved in getting people access to use digital tools. There are specific steps that healthcare systems can take to facilitate digital inclusion. And this really matters because while digital health tools offer significant conveniences and advantages, we don't want people to be left behind. So now you all can ask me anything.
Cindy, that was absolutely terrific. Thank you so much for walking us through not just the tremendous publication, but also some really terrific examples and some quite eye-opening statistics, actually. A good reminder for those of us who are in the sort of digital health space every day, being sort of quite enthusiastic about all of this, that there's we have to keep this absolutely front of mind. A couple of reminders for folks on the line. So we'll spend the rest of our time together more in discussion, and particularly having the opportunity to pick Cindy's brain. So if you have a question to ask, you can do so by raising your hand against your name in the participant list. You can do it by popping a question into the chat. And I'm going to, while folks sort of gear up for that, and of course, feel free to put your, if you're somewhere where you would like to, pop your videos on to engage in the conversation if you'd like. One of the things that I found sort of really fascinating about your publication, Cindy, was the word choice. And we were chatting about this a little bit before we hopped on and went live, specifically talking about digital inclusion. And I hadn't heard that term very much. We always talk about sort of combating the digital divide, but the sort of digital inclusion piece seems much more thoughtful and deliberate. And I wonder if you could talk to us about sort of that language and how we should sort of use that going forward.
Mm-hmm. Well, I think that language really comes from exactly what you just said, a reaction to combating the digital divide and kind of the fight that brings up in your mind, as opposed to a strategy of bringing everyone in, and how can, particularly in healthcare, because that's kind of what we do, we want our patients to be engaged. And so using that language of inclusion, I think helps us to think more about that kind of approach of bringing people in and meeting them where they are and getting them, to a point where they can participate, as opposed to just more of an infrastructure focus, on this idea of a digital divide, where often people think it's just a urban versus rural divide, which is actually, that is true, but it's not the only part of the digital divide. And focusing really just on that digital divide, kind of tricks us into thinking that just putting down internet cables will fix it. And that's not true. We know that people need, not only the devices, but the skills to use it, and an understanding about why. There are a lot of populations where, they may not want to use a patient portal because they don't understand the value of it. And once you explain that, they're more willing to use it. But that takes time to explain it.
Absolutely. And I really like that. And I've seen it before. I've seen people talk about, okay, well, we need to improve broadband access, okay, well, we need to make sure we do it on a more simple device that everyone has access to, which I still sort of problematize, not quite, like, it's pretty ubiquitous, but, our goal here is to make sure that folks don't fall down the cracks. Rachel, I'm going to come to you next. You pinged me in the chat to say you had a question for Cindy. Do you want to unmute yourself? There you go. Go ahead.
Hi, Cindy. Thank you so much for the presentation and for this really fantastic work that you're doing. It's going to help all of us. I'm Rachel Chassie. I'm DIME's Director of Innovation, and I am thrilled to bits for your presentation. So thanks again. I have some questions about your really fantastic recommendations. So I'm cheating. I can actually access your slides myself, so I'm looking at them. So your recommendations are really fantastic. But my question is, who are these recommendations for? Right. So one of yours is systematically assess access at the individual patient level. And you have other ones too about, digital and inclusion informed strategy. So who are these recommendations for?
Yeah, that's a great question. I mean, so broadly, we put them out there to a healthcare system, and you really do have to take a system approach, I think, to addressing this, because it has to be comprehensive. It has to be, consistent in that everyone is asking patients about their access, and the idea of kind of, looking more broadly at the population level and understanding what the needs of your population are, that can really only be done at a health system level. But also, we sort of want to speak, to individual providers as well, right? To be able to advocate for those sorts of things, but also to have those conversations, with their patients about, do you have someone at home who can help you to do this? Or even just not saying, oh, there's an app for that, right? So put this app on your phone and, track how much water you're drinking. Not everybody has a phone that can do that or has the skills to do it. And so, that's why having that systematic assessment helps providers to be more clued into it. But I think the other piece of your question is, whose job is this in a healthcare system, right? And that is, if you had the answer to that, I would love to hear it. I can tell you what some organizations are trying, and that's different ways of kind of building this, what they're calling a digital navigator into other positions. So like a care coordinator could have access to information about, resources for getting low-cost devices, or how to get people signed up for the FCC's Lifeline program, which is like $10 a month internet access. And so, those sorts of things. So they can do that kind of screening, have those resources available, and point people in the right direction. Other organizations have taken an even more kind of comprehensive approach of training community health workers to do digital inclusion. That's something we're working on, particularly with the Pact neighborhood that I mentioned, so that they can actually go out into people's homes and do the fabulous work that community health workers do, helping people to get online and get connected and sort of, close that loop. So those are some strategies. I hope that we see more moving forward, but it's a challenge, with every social determinants of health question, right? How do we work that systematic assessment and then be able to do something about it into routine care? That's the $64 million question.
Thanks so much for that, Cindy. I asked partly because DIMES is at the intersection of a lot of different stakeholders, both in the digital medicine space, but also folks who are trying to do great equity work. So this is really helpful to think of our different partners and stakeholders about things we can all do. It's different for each different kind of people where they sit and where they come to the conversation, but this is really helpful. Thanks again. I did have just a quick comment too, thinking about more about how some folks may only access the internet from their mobile device, especially in the context we talked previously about applying for jobs. Research has shown that whenever there is, job application process and there is an assessment for folks to do, some sort of, skill assessment, if people do that on a desktop versus a mobile, results are different, even if they say the same kind of stuff. So people can also often, be at a disadvantage if they only have access to apply for jobs through mobile. Super not great, even though we try and make those available in the mobile aspect. So additionally, thinking of ways to help people kind of access things. So I'm done for that question. Thanks so much, Cindy.
Yeah. So tailoring your applications so that you can use them in both ways. Yeah.
Fantastic, Rachel, great question. I have some follow-ons, but we have some burning questions from other folks in the audience. Demilade, let's first of all, tell me if I'm mispronouncing your name, and if so, I apologize. Also, please go ahead, unmute yourself and pose your question to Cindy.
You got my name right. It's Demilade Adedinshewa. So I am a non-invasive cardiologist, and I'm actually very new to DIME. I think I just joined like less than a week ago. So I was really excited to be part of this. Thank you. So I guess my question is, I've just been thinking about this because I'm really interested in AI applications, specifically in the field of cardiovascular care. And, there's some tools that we've been working on, some AI algorithms and applications that we're hoping that, we can scale so that multiple people will have access to it. And what you bring up is a big issue. I pulled up the paper as well, is looking at, it seems like the main focus kind of has to do with like the internet specifically as the infrastructure that is missing, because we see that a ton of people have access to like a mobile device. I was looking at this website recently, the weasocial.com, that has kind of like tracks metrics across the world and how many people use cell phones and things like that. And we were hoping that we could take advantage of this. So my question is, as we, when you were working on this paper, did you think about the potential for AI applications that can be deployed at the edge such that it does not require cloud computing, you sending it back to the internet, and what role will this have in in getting some of these tools or some of these applications to people who have cell phones but might not necessarily have a stable internet?
Mm-hmm. Yeah, that's a great question. And I don't know that that was, top of mind when we were writing this paper, but I know it is a very important and so rapidly growing area that, we're taking advantage of all of this kind of technology. I think, part of what needs to address that is when these tools are being developed, using a user-centered design approach, which can mean different things in different settings. I'm not sure exactly what kind of tools you guys would be using and how much the patient as the person these things are connected to, would need to interface with it. But when that's an issue, having patients of all different types, be able to be involved in the design of those tools, and really just keeping in mind that if we really want to take advantage of these capabilities, I mean, there are so many applications in which AI and machine learning can really help us in ways that have never been possible before, but we need to make sure that these aren't going to leave people behind in the process. So a smartphone is fantastic, but you have to be able to, have the most up-to-date software and, all of those sorts of things. And some of the ones that are like designed, specifically targeting older adults are more limited and might not be able to accept those kinds of applications. So, and I don't know also if, if what you're talking about requires like an additional tool, some other sort of monitor, and then someone to support, using that in the home, or that's a common thing, I think, in more remote monitoring.
Right, right. And I agree with you. I guess what I was thinking is I can give you an example. So there's this company called EcoHealth that developed this digital stethoscope where they can basically record like heart sounds, and they can also record a single lead ECG at the same time by placing it on the patient's chest or with their fingers as well. So there was this app that was based on an AI algorithm that was actually created at Mayo Clinic that was licensed to EcoHealth, and they got emergency use authorization for it during the COVID pandemic to be able to screen for left ventricular dysfunction. So what they were able to do was take this algorithm and make it available as an app that will be embedded in the phone or in the tablet or in the device that is being used, such that when you place the stethoscope on the chest, you can get the results in real time without having to send those ECG strips, back to, the internet, and then it gets analyzed and the results get sent back to you. So that kind of eliminates, not having internet at that time point, that you can get results wherever you are, so long as you've downloaded the app. Of course, it will still require you downloading the app, but you can do this before, or maybe in the short period that you have access to internet, and still be able to use this tool, which I thought was really neat. And I didn't think about that when I was like, trying to design a different study that we're working on, okay, so how do you have, the algorithm available right there and then? Do we need to start thinking about edge applications as opposed to internet-based applications?
Yeah. And so is the stethoscope something, does the patient have the app on their phone and then they also get this stethoscope and they put it on themselves, or how does that work?
So it was designed to work both ways, like for the provider to have it, or if a patient was interested in having it. So for like remote monitoring, the patient can put it on at home, place it on their chest, and their provider can hear it wherever they are. Right now, I think most people are just really using it for the providers themselves. So if you show up to the clinic, or if the provider saw you maybe somewhere outside of the healthcare setting, they could still place the stethoscope and still get the results. So the app will be downloaded on the provider's cell phone or on their tablet.
Mm-hmm. Or I would also imagine like, EMS services might find that useful as well.
That is correct. So far, though, the only thing that it does is detection of LV dysfunction, and we're hoping that we can take it beyond that. There's so many other algorithms that they're working on to see if they could develop, similar things that could identify different cardiovascular pathologies, say, for instance, maybe a STEMI or something in the field.
Mm-hmm.
Similarly, it's so great to have like a specific example, and I really like that. And I think that goes back a little bit to Rachel's question around sort of who's responsible, because Cindy, your terrific paper is thinking about once we have these tools ready to go for deployment, right, when they're ready and out in the wild. And then I think, our community in particular, if we think about our responsibility for sort of selecting and developing the right tools, Demilade, I'm thinking about that example, and I'm thinking of a feels like whack-a-mole sometimes, right? When you look at all the challenges that we're trying to balance. I was also chatting with someone the other day, and they were talking about a particular sort of digital therapeutic product. It was some cognitive behavioral therapy, and you would literally need the highest storage smartphone that any particular manufacturer makes in order to be able to download that. So, you know, the whack-a-mole piece is true, right? Because if you're not going to do it sort of, if you're not going to rely on sort of cloud processing or whatever, and you're going to actually put it on the technology to overcome some of those data challenges and connectivity challenges, then like, are you just transferring the problem to the actual sort of handset or tool or technology? And so, Cindy, I think your guidance, and this is something, you know, we all need to get better at, is, you know, the user-centered design. You know, we, for those of us who spend our entire day sort of carting these things around, sitting at a table with all the smartwatches, we don't think like that. So let's make sure we're actually talking to the patients that we're all here to serve to make sure we're getting it right. So Demilade, what a terrific question. And Rachel, it brought us back to your remarks as well. Anzar, let's come to you. You've been very patient. Thank you. Go ahead and pose your question to Cindy.
Thanks, Jen, and thank you, Cindy, for this paper and this talk. You know, I think it's kind of a wake-up call, for at least for me a little bit, because I spend my entire day thinking, how can we digitize this? How can we digitize this? How can we digitize this? And so it is, and though we'll think, you know, during product development, how can we increase the accessibility of this technology to as many people as possible? We don't often think that much about the sort of problems that you're bringing up. My question is, how much comfort can I find in that these trends may get better over time? In what direction are they moving? And can we sort of find some comfort in that?
Yeah. I mean, so I guess I'm an optimist. I would say, yes, we can find some comfort in it. I mean, I know I like, you know, the kinds of research that brings those tools out into the market. It's a staged process, right? So it starts out with these high risk, high reward, kind of cutting edge tools, right? And then the next stage goes to more application and kind of how do we get things that are usable, which then can develop, you know, another layer of technological innovation, I guess, to help, you know, cut down on processing speeds or, you know, change the interface so that these tools are more usable. So in that sense, I guess I'm an optimist. I guess I would also say I'm a bit of a realist in the sense that, you know, I mean, we've had EHRs for a long time. We know they aren't user-centered design tools. We know that there are a lot of ways that they make it harder for patients and providers to interact, and they don't always have the most useful way to help, you know, patients or providers. And, you know, I guess a part of my fear is that once, you know, with COVID, this issue became a very hot issue. And, you know, there are restrictions that were relaxed so that people could take advantage of, you know, multiple platforms for doing telehealth. And you didn't always need the newest smartphone to do that. Those are temporary. And so if we don't keep this topic, you know, front and center, then people who didn't have access before COVID may gain access during COVID and then lose it again. And that's, I think, what we have to guard against.
Thank you.
And a terrific question. And I want to come to Emmanuel next because he had a really thoughtful comment in the chat, but just riffing off of that for a second, you know, I'd love to see if we have time to get to later in our conversation sort of incentives, because what worries me is people have always slipped through the cracks. We know this. We know that there are hard to reach patients. We know there are patients who, you know, and individuals, and we're all people before we're patients, right? That we've sort of poorly served historically always. And now we just have a new way to poorly serve new sort of subsets of the population. You know, what are the incentives that we need to build in? And specifically as we come out of COVID, let's chat about that in a second, and maybe everyone can noodle on it. In the meantime, Emmanuel, you've got a really thoughtful comment in the chat here. Do you want to unmute yourself and give voice to that? If you're somewhere you can do so, that might not be possible, which might be why it's in the chat. Yeah, sorry about that. So I just, if you haven't seen it, just this idea that, and maybe I can flip this into into a question if I don't butcher it. You know, we think about sort of reaching out from the healthcare systems, and that's a really nice and important theme, I think, from your paper, Cindy. How do we think about maybe flipping that model on its head? Is there value in doing that and starting from within communities and sort of reaching out towards the care that's needed?
Can you, I know, I'm sorry that Emmanuel can't mic on, but I'm not sure I understand what the flip is.
How do we think about starting in communities rather than starting at the health system?
Oh, got it. Okay.
Sorry, that was my fault.
I mean, I think that that's a great question. And I think it shows, you know, a lot of communities have been doing community-based public health work for, you know, for decades, right? And the connection between those two, between the healthcare system knowing about and taking advantage of those kind of collaborations is really where we need to strengthen that. And I think, you know, we are learning about, you know, these learning healthcare systems, learning communities come together to facilitate some of that, but we have a long way to go. And it is an approach that I really support, you know, that communities kind of do what they need to do, understand their needs and how best to address them, and the healthcare system can support that. So some things that I've read about that happen in that way are, you know, like I was saying, community health workers going out into the community and doing work. You know, they address pretty much every area of health that a community health worker has done work in, but adding on this layer of digital skills. So now there are health systems that are hiring community health workers because they know that that's a strategy that allows them to reach a lot of people and get, you know, take advantage of the local knowledge and trust and kind of understanding, you know, what that community needs. So they're hiring these folks to do that kind of work, to get, you know, reach out to people, get an understanding of what the needs are. The folks who did the Pact survey actually were community health workers. And that's part of why they got, you know, such a great response during COVID, because they're trusted members of the community. And so, you know, that's one way that it works. I wish I had the answer for how to make that happen, you know, more often. My training in health behavior and health education actually started in community-based participatory research, and career twists and turns took me into healthcare, but it's an area that I think is super important and often neglected. So I don't know if other people have thoughts for how you can make that magic happen.
Yeah, and I want to riff on that a bit. And Cindy, it's great that you bring sort of the experience and your sort of history of being part of sort of community-based participatory research. Like, I think Emmanuel's sort of suggestion to think about flipping this on its head a little bit. I haven't done CBPR sort of extensively before, but, you know, I've spent my career in healthcare sort of advocating for, you know, patient engagement, for example. And one of the things I am starting to get a little bit jaded on is I feel like, for example, so I'm taking it to sort of where I have some experience, like patient groups and patient advocates have been sort of screaming into the wind on this for years. And I'm sort of tired of putting the burden on them, right? It's up to the sort of the developers of medical products and the sort of care delivery systems to go to them and listen and ask. And I worry about us going the same way as we think about this kind of work and putting the burden on communities, because there are some communities, for example, the one I live in, where we don't have this burden. We don't have to go out and advocate for that. Why? Because every single one of us has broadband in the house and we use tools and technologies every day and we're digitally literate. So that's a nice problem that we don't have. Like, how do we make sure that we're not, in addition to underserving certain communities, like overburdening them to solve the problem for us? Like, that's something that like I struggle with a bit, and I'm not sure sort of how we move forward here.
Yeah, I know in healthcare, in primary care, there's been a movement to have patient advisory councils to advise, you know, healthcare systems in decisions that they make. And those can be awesome and engaged, and the right leader can really take that information in, or they can be rather perfunctory and just checking a box. And I know that's been an issue with our institution, that the people that volunteer for those are people who have the time, right? And so I know in our department in particular, there's been a big push to schedule the meetings, after normal working hours, so that people who have a day job, or who need childcare, during that time, are able to participate more, and making more of an intentional effort to make sure that your advisory council actually looks like the patients that you're serving, and isn't just, the people who have lots of time to volunteer in the day. And on top of that, making sure that the providers that they are interacting with or informing understand why this is important, and that these people aren't just filling out satisfaction surveys. They're an integral part of this team, and their feedback really matters, and we want critical feedback from them.
I really like that. And yes, I've definitely seen a few performative patient and family advisory councils in my time. So I like the idea of being serious. It's not just something you do to check a box. Rachel, you put your video back on, and you've done a lot of work in this space. I get the sense you have some comments. Please go ahead.
We work closely together. When you can tell that me going off camera means I got something to say. Yeah, so this is a really great question too, Jen. And I think it also helps kind of tie it all together for all of us on the line. So my initial question was, who are these recommendations for? Also getting into, we've got a lot of folks in DIME. And also I think it goes a bit towards the questions that Demilade and Anzar had, right? Like, how can we all take a look at this? And I think, Cindy, you hit it right on the head. These people are, in the community, people are volunteers, right? So people, whenever they're available from their full-time job, from childcare, parent care, walking the dog, meal planning, trying to eat and be a person, right? So how can we no longer continue to burden these kinds of people? I think it puts also a lot of, I think if anyone is building any kind of product that's a healthcare product, I think a lot of the burden has to be on the builders. Why are we building products that have to be 4G or 5G or whatever the heck G we're on now? Whatever, a lot of things really can be just fine on 2G. What are the kinds of technology? Does this technology absolutely have to have the most top of the line, whatever that is? And are you sure? And if that has to exist on that kind of technology, are you okay with yourself and your R&D team to say, we have to have this technology, which therefore cuts out a lot of the most vulnerable population? Are you okay making that distinction? Think about that and think about why. And if that's not super great for your company mission, your personal ethics, and kind of think about how you can build great products that get great information that can be really helpful, but also helps everyone. Because if we build a product from a kind of bottom up approach, everyone gets help. So if we can build these products in a way that is intentionally designed to help folks who perhaps have less resources, then everyone else moving up the chain will even build a greater product.
Yeah, and I would say even we have to hold, our federal funding agencies accountable for keeping that in at top of mind, because that's like NSF funds these high risk, high reward projects, which are great and fascinating and cutting edge and important. But if they are only going to help the people who have resources, and they're only taking advantage of the most cutting edge resources, then is that really where we want our tax dollars to go?
This is tremendous. Hassan, I saw you raise your hand and put your video in response to some of the comments. Go ahead, please ask your question or share your thoughts.
Yeah, so this is, thank you so much for organizing this. Thank you for the wonderful paper. I, like Anzar, am someone who is constantly excited about the digital tools that are coming out right now and their potential and how they can change the world. But then often, on your weekend in the back of your head, you think, hey, wait, remember we did this so that everybody has access to this. That's the wonderful part about these digital tools. So thanks for the paper. To Rachel's comment about the responsibility somewhat lying in the builders, I totally agree with that. So I work as a researcher at a hospital in Boston. We work on a platform that tracks surgical outcomes for patients that have had brain tumors resected. And when we started building this platform, two of the things that we considered were one, first, the demographic of our hospital, right? That in and of itself is somewhat frustrating as a researcher in this space, to work at a premier institution and then realize that you're really serving the people that don't actually need this technology. You know, everybody that comes in to see you is able to come in to see you. So that's one frustration that I think is interesting. I'm sure that's a systemic thing due to funding and that sort of thing. But what we decided to do was, one, to make sure that we build both an iOS and an Android version. I think that's super important. And then two, in regards to data, you know, the way we store our data on each individual user's phones is the sensors are working in the background, gathering this data, and it hashes and encrypts it locally on the device. And we specifically designed it to not upload that data when you're on a data connection or a cell connection. It will only upload it while you're on a Wi-Fi connection. So, you know, for me, that didn't really make sense, because how long have a lot of us had unlimited data plans, right? But again, you know, not everybody has that. So those were two solutions that we found really useful. I did have two questions very specifically from a research perspective of, when consenting patients for studies like this, has there been a lot of research done, or any research done, about how language and consent should be altered for certain socioeconomic classes, or the way you explain things, whether there's hesitancy for certain socioeconomic classes to adopt certain digital tools, that sort of thing. You know, I can tell you we've recruited probably about 600 patients, and in those 600 patients, probably 5 decided not to participate. Those 5 were 3 very elderly patients who could not remember their app store password, and 2 patients who worked in cybersecurity. So they weren't very pleased with having an application monitoring the sensors on their phone. But I would think that, again, this is certain demographics. So if we moved it to, you know, a community hospital, I wonder how our recruitment rate would change, and how maybe the language and consent and how you talk to patients should change.
Yeah. So I don't know that I'm so up on the language of consent, other than I find it incredibly frustrating that, you know, I feel like I want more flexibility from the institutional review boards that I encounter, in terms of, you know, making a consent form that is understandable and, you know, accessible. One of the ways that I've kind of been able to, you know, get some leverage there is by, you know, putting a pilot consent form in front of patients, and, you know, asking them to tell me what does or does not make sense, and you know, pushing back with their criticisms of, you know, this was not understandable. So that, I mean, I think for anything, putting it in front of your users and getting their feedback as early on in the process as possible is helpful. But I think, you know, the kinds of tools you're talking about too, a lot of us, you need a very nuanced understanding of the data to really know the challenges with that. You know, my understanding of it is very different than my 21-year-old daughter's understanding of it. And so that it's another layer of complication.
Fantastic, Hassan. What a great question, and thanks for. Oh, you're on mute. I'm so sorry.
I just said thank you.
And also really terrific sort of research that you're doing, and sort of appreciate you being willing to share sort of some of the benefits of where you sit, but also some of the frustrations as you think about sort of being a developer and those questions you bump up against. There's a lot for all of us to learn. Anza, you have another question. Go ahead.
Yeah, kind of a little unrelated to what we've been talking about, but I grew up in Pakistan and kind of saw firsthand the effect of sort of lack of access to technology that can have on people's lives, not just in healthcare, but beyond that. But some of the ingenious stuff that I saw come out of it was technology actually helping be the solution to that problem. For example, people using their cell phones for banking when they wouldn't actually have in-person or sort of more analog ways to do so. So can we think of examples in healthcare where lack of access to resources or even care could be overcome by technology in such a manner that isn't exclusionary, but actually brings in a lot more people than it excludes? And I guess, Cindy, this is just a question for you, but just generally.
Yeah, I've got an idea for that. That's a really great question. Cindy, I'm stealing your thunder here, so you can shut me up at any time. And so you're exactly right. A lot of places really have no access to things like internet at all. But technology has really shown to be an opportunity to technology can be a solution to its own problem. Let me talk that out. So an idea is that text-based care is really helpful. Smartphones, people can't really access a lot of internet, but they can do text, right? And so even for a lot of refugee populations, getting healthcare through the text-based system really works. There is kind of layered considerations there. You know, how do you handle HIPAA from a texting situation, collecting all that healthcare data in a really safe way? But technology can help if you look at it from a way of like kind of like texting as opposed to like a patient portal. Is there a way for you to text like a front desk of a healthcare provider, for example?
Yeah, and we saw that with, you know, the telehealth response to COVID, right? That providers were able to do FaceTime on their phones because they relaxed some of the restrictions. And that's the fear is, you know, I hope that we learn from that flexibility is really important for everyone. I mean, I know the difference between doing telehealth via a portal versus just getting a text on your phone and you click a link and it takes you there is huge. The skills required to do that. I mean, even just remembering a password is sometimes that's just really hard. So I hope that we keep that flexibility, although I'm not so optimistic that we will.
And what a great question. And Demilade, I was looking at your statement in the chat, and I'm glad you've raised your hand. You have some examples. Please go ahead and share. And I like your thinking on this.
So yes, I guess my comment is kind of similar to what Anzar is talking about. I know we were saying maybe we need to tailor interventions to like suit the environment where we are putting them in, but also, you know, not to disregard the fact that technology can actually be a huge help. So I'll just point out an example, and this is something that I learned, that there's some communities across the world. So for me, I also grew up outside of this country. I grew up in Nigeria. So I understand, you know, like firsthand what it means not to have access to a lot of things. And the issues that people deal with in different places is different. So like here, we're kind of like a little bit more concerned about HIPAA and privacy, but, you know, in a developing country where there's no access to a doctor, they're just more concerned about getting help, getting access to somebody. And some of these environments they use a shared cell phone, a shared, you know, device to get access to get whatever they need. And at that point, maybe HIPAA is not priority for them because that's not what they need in that environment. So one example that I found out is communities that do not have access to clean water actually have access to mobile technologies, which, you know, you would think is surprising. And then, you know, they talk about, you know, industrialization and how it takes time and how, you know, some countries are behind, but we do know that it can skip all of these levels. If places that don't have access to clean water have access to mobile technology, it skipped all of those parts where, you know, there's water, there's electricity, and there's all of that. So if we know that they have access to mobile phones, maybe what we should be doing is focus on interventions that can use this, just like what Anzar was saying, how can we capitalize on this? And that's why I thought about the example with apps that you can download onto a device. I know it also comes into the issues of sizing, but maybe there's just one tablet that this community or this environment or this home uses. That is better than nothing. And that gives them access through these digital tools rather than saying, oh, it's not going to work because they don't have internet.
I love this. And as I start to think about tying some of these pieces together, you always hear, not always, I think increasingly I would like to hear more of things like privacy by design. And now I'm almost thinking, I reacted most immediately, Cindy, to your choice of the word inclusivity. We've talked about the responsibility of the sort of digital health community. How can we think about inclusivity by design, right? How can we think about starting with the lowest technical requirements, with the lowest digital literacy requirements, and using technology, not only sort of the bleeding edge of what's possible, but also how can we reach the most people? One of the things that increasingly I'm trying to think about in our work at DIME, and that I've learned from everyone in our community, is we need to think about not only sort of raising sort of mean health, but also where's the distribution of that going? And I think that's a really powerful way for us to think about sort of your calls to action in the paper, Cindy, and how we dovetail onto that and saying, you know, this is how we do it in practice. what's the upstream responsibility to make sure what falls into practice is actually as, that we've done our inclusivity by design to make this as easy as possible to action in the real world.
Mm-hmm.
Cindy, this was fantastic. And also everyone on the line, what a terrific conversation. I learned so much today. Cindy, any closing remarks, any calls to action before we wrap?
Just thank you all for engaging in this discussion. That is my favorite way to do a presentation. I don't like talking at people, so I appreciate the conversation a whole lot. And I guess my calls to action are, keep this at the front. Talk to the people who are going to use your products, and keep them in mind.
Fantastic. Cindy, sorry, I'm struggling today. Cindy, thank you so much for your time today. Thank you everyone for being on the line. One quick moment, I'm going to just share the screen again before we break. I want to remind folks of a couple of upcoming events here at DIME. So we're launching the playbook on April 30th. So if you haven't registered for that yet, please head over to playbook.dimesociety.org and make sure that you are live on the line for that launch. And also our next journal club, our next discussion, Anza, you're going to be leading this. You had a terrific publication recently around the use of these tools specifically for mental health and some of the challenges and promises. So I hope we're able to tease up some of these threads and look at them specifically through the lens of, improving the provision of mental health, which is something, again, Cindy and I were talking, COVID hasn't sadly sort of done much more than shine a light on all the challenges we've had all along, whether that's disparities, whether that's mental health, so on and so forth. So let's use this opportunity. Let's think about it. Let's take action while it's forefront of mind and really capitalize on the opportunity on deck. Cindy, thank you so much again for sharing your time with us. Thank you everyone for being on the line. Have a wonderful day.
Take care. Bye-bye.
Bye-bye.